Hi, my name is Rebecca Torres, and this is my Case Connections number 4 presentation for the University of New England Medical Biochemistry class. So for case number 2 is where I will start. In case 2, patient A's presentation of high phenylalanine levels suggests that there is a defect in the phenylalanine metabolism, which is shown here in this figure. As a consequence of this presentation, tyrosine will become a nutritionally essential amino acid. The reason that tyrosine will become nutritionally essential is because in a normally functioning individual, phenylalanine is converted to tyrosine by the enzyme phenylalanine hydroxylase, which requires BH4 as a cofactor, as shown here. Phenylalanine's conversion to tyrosine requires BH4 as a cofactor to phenylalanine hydroxylase in order to convert phenylalanine to tyrosine. If there is a deficiency in this metabolic pathway, then phenylalanine accumulates and does not convert to tyrosine. Tyrosine must become nutritionally essential because it is crucial since it is the substrate for the synthesis of epinephrine, norepinephrine, and melanin. It must be provided nutritionally if phenylalanine is not converted properly, since norepinephrine, epinephrine, and melanin are required in the body. The potential causes of the presentation of phenylketonuria are either a defect in the enzyme phenylalanine hydroxylase or a deficiency in the cofactor BH4. This cofactor is necessary for phenylalanine hydroxylase to function, therefore required for the conversion of phenylalanine to tyrosine. The test results presented for both patients after the administration of BH4 shows that the patients each had different causes of phenylketonuria. In this graph, after administration of BH4, patient A's phenylalanine levels increased. This suggests that the patient does not have a deficiency in BH4, because if they did, then the patient would be able to use that BH4 to activate phenylalanine hydroxylase and convert phenylalanine to tyrosine, and their levels would not increase, they would actually decrease. These results suggest that the patient A has a deficiency in the enzyme phenylalanine hydroxylase. Onto patient B, after administration of BH4, patient B's phenylalanine levels actually decreased. This suggests that the patient has a deficiency in BH4, which is why they had initially high levels of phenylalanine, since they were unable to convert it to tyrosine without the presence of the cofactor BH4. Patient B's cause is due to a deficiency in BH4, so upon administration, their phenylalanine levels lowered and likely returned to a safe range. That concludes my discussion on case number 2. On to case number 3. Here is the data presented for the patient's plasma urate levels and urinary uric acid levels. And here are the normal ranges for a normal patient. As you can see here, the patient's plasma urate levels are above normal plasma urate levels, and the patient's urinary uric acid levels here are actually lower than a normal urinary uric acid level. The best explanation for the presentation of gout in this individual is due to a decreased urinary excretion of uric acid. In this data presented, the plasma urate level is higher than normal, however the urinary uric acid level is lower than normal. This data suggests that there is some sort of deficiency in the excretion of uric acid from the body, since the high levels found within the blood are not parallel to the low levels being excreted from the body. If the excretion of uric acid were working properly, then the levels of urinary uric acid would be within normal range, if not higher, since there is a high level of plasma urate. This low level of urinary uric acid suggests that the urate and the uric acid is not being excreted properly, and there still remains a high level of this plasma urate in the blood, which essentially is causing the gout. The other two choices are not consistent with the data presented for multiple reasons. If the root cause was due to an overproduction of purines or a decreased salvage of purines, then both the plasma urate levels and the urinary uric acid levels would be above normal range. In these two figures, you can see here on the left the degradation of purines, which produces uric acid. The degradation of purines generates uric acid, which enters the blood and is excreted from the body via urine. With an overproduction of purines, there is an overproduction of uric acid, which can accumulate and cause gout. Here on the right shows the salvage of purines, which helps to work to lower the uric acid levels by converting adenine, hypoxanthine, and guanine to AMP, IMP, and GMP. A decrease in the salvage of purines can also lead to gout because purine salvage helps to lower the amount of uric acid being produced. With a decrease in this salvage, uric acid will accumulate, causing gout in an individual. Both of these causes would result ultimately in a higher than normal plasma urate level and higher than normal urinary uric acid level. In the patient we have seen in this case, his plasma urate level, again, is increased. However, his urinary uric acid level is decreased, indicating that there must be some sort of defect in the excretion of this uric acid. The potential impact of the individual's dietary modification from diet soda to regular soda is that he is supplying his body with additional fructose, which impacts the production of purine synthesis. As you can see here, the breakdown of fructose produces AMP, which impacts the purine synthesis pathway. With an increase in fructose in the diet, there is an increase in fructose metabolism and thus production of AMP, a purine. Since the individual presented in case 3 has increased his fructose consumption, this will in turn increase the synthesis of purines, leading to an overproduction of purines, accumulation of uric acid, and thus gout. With this additional information about the individual's diet, it is likely that the cause of his gout is due to a combination of an overproduction of purines, hence an overproduction of uric acid, and a decrease in the excretion of urinary uric acid. So he is producing more purines than normal, which is increasing the plasma urate levels, and he has a deficiency in the excretion of this urinary uric acid, which is keeping it within the system, within the blood, causing an accumulation and causing gout. So the combination of these two causes might likely be a cause of why he is presenting with gout symptoms. Here is the pathway of purine synthesis, and much of gout is actually related to a defect in this enzyme, the PRPP synthetase, causing the inflammatory condition of gout. And that concludes my presentation for the case connections number 4. Here is a works cited page for the information as well as the outside images that I used. Thanks for watching.